two very important people from the University of Minnesota and the PhD program, and thank you so much, Michelle. Thank you. Thank you. And a little bit of history about this project. I can tell you at the beginning, it was just like the opportunity to apply for PhDR grant came up, and we were thinking what we can do. It's not working. Oh, it's working. Because we were looking for a collaboration with academia. And back in time, Juan Pablo Higuera, who is a former research associate at HACER, and myself were talking about what we can do. Ideas came, ideas went, but we all of a sudden learned that Gabi Bustamante was at the U making her postdoc, and she was working on something related to cancer. So we came together and talked about it. And back in time, she said, let's do some study on cervical cancer. I can tell you at the beginning, Juan Pablo was like, what? Cervical cancer is not for me. Sorry, I cannot be part of this team. But later on, he understood that the research Gabi was proposing to us, it was really interesting because SAGE has a very high rate of participation of Latino women in their program and screening for cervical cancer. So that raised the question, why? Can we approach something really positive and perhaps understand why it's working and eventually propose ways for it to be replicated with other cultures, with other communities, or even expanded it with our Latino community as well. So we engage in this project and we work very hard in building it up. I just remember the first meeting, it was with a large team of almost 7 people there at the table at the U. And we were trying to figure out how we were going to be working on, and ideas also were decanted, and we ended with a beautiful proposal. So the team that was very much involved in the project was led by Gabi Bustamante as academic principal investigator. I had the honor of sharing that co-responsibility with her. And also at the beginning, Jessica Pakunen was a member of our team with come on in, with Juan Pablo Higuera, and we start to design the project, the study. And later on, Monica Cruz, who was at that time our research associate, joined us, and the most recent addition and most stellar addition to our team was Alex Jensen, who is there in the back with us. She's going to be talking to you as well. And from the University of Minnesota also, and Larry McRee were part of the team. So this is a team that worked together in this endeavor. And I can tell you at the end, we found several things that is why we want to share them with you. Also, we did have the magnificent support of a steering committee. You see the names there, and I can tell you whenever we were meeting, they were having wonderful ideas. 2 of our members are here, Lily Tobon and Gabriela Vasquez, but Nidia Celaya and Lupe Quintero and Socorro Felton were there with us, really supporting and giving us great advice as to how to move forward. So I want to recognize the work of our steering committee. So thank you as well. And you deserve a round of applause for them. Thank you so much. Without you, this project will be different. But what you're going to be listening today is going to surprise you. And who better than Gabi to present the project? So this is our project. This is our leader.
Thank you, Rodolfo. I say that this was the project that made me an independent researcher, but really what I learned is that no research is independent. That you do it as a community, you do it as a team. So it is our baby, our project. So hopefully we can do it justice in like the few minutes that we have. And thanks again for sharing them with us. The team that Rodolfo shared has changed, but they have all contributed and supported this project in so many different ways. So just some key concepts that we want you to take away from here today is uninsured Hispanic women identified facilitators of cervical cancer screening at multiple system levels. There were tight networks, solidarity, and word of mouth messaging, all facilitated service uptake of the SAGE program. And participants from Greater Minnesota had limited resources and more experiences of racial discrimination compared to participants from the Twin Cities. So I'll unpack everything that I've just said. So just some background about cervical cancer, because like Juan Pablo, when I first approached him, you know, being, cervical cancer, what is that about? When I talk about cervical cancer, I'm referring about the cervix, which is a part of the a female body. And when I do want to say that my language tends to be a little biased because the data often uses the word woman to refer to people with a cervix, although there may be people who have a cervix who do not identify as women. So I do want to start with that. But in the US, there are 12,000 new cases of cervical cancer per year and 4,000 deaths. Human papilloma virus, HPV, causes nearly all cervical cancer cases. And over 93% of cases can be prevented through screening and HPV vaccination. So all to say that cervical cancer is preventable, but not the same for everyone. So why is that? There are barriers. And you can see here in the slide that from data from 2019, unfortunately, the rate of both incidence and mortality is higher for Hispanic and racialized minorities. Other racialized minorities, you can see the in order of incidence, Hispanic women have the highest mortality, the highest incidence, and one of the top mortality rates of cervical cancer. So why is this happening? There are higher barriers, structural barriers at multiple system levels that is happening, that is preventing people from accessing HPV vaccination and screening that could save their lives. So then I found out about the SAGE program, which is part of the National Breast and Cervical Cancer Early Detection Program at the federal level, which provides free cervical cancer screening for people who qualify based on income, insurance, and age. So each state has their own ways, their own definitions, but these were the definitions at the time we started the study. They may have changed now. So with these two pieces of information, I said, well, okay, so Hispanic women are dying more, are getting more of this disease. There's this program. Let's just start a campaign to get more Hispanic women to use this program. My postdoc is done. This is what I'm going to do. I'm going to teach Hispanic women about this program and get them to use this program. But what happened is that actually Hispanic women represent 63% of the clients of this program already. So when I went to SAGE and I said this idea, let's do a campaign for them, they're like, actually, can you do it for other communities? And that was not what I thought about. That's not the community I was part of. That's not the community my partner was part of. That's not the community, the project we wanted to think about. So then we just stopped and thought, and we were like, why are we solving the problem that is not there? Why are we asking? That's not the question we need to be asking. So then we decided to flip the question and say, well, maybe our approach is wrong. Maybe we need a bright spot approach. We need un poco de luz. Why are we not learning from this program that it suggests that we are reaching the women that need the program, right? So indeed, if you can see in the slide, Hispanic women represent 7% of the Minnesota population, 15% of the uninsured population in Minnesota, and again, 63% of the SAGE clients of this program. And this is repeated across several states in the United States. So this is not entirely unique to Minnesota. So we got this information together and we said, okay, let's identify facilitators that allow uninsured, low-income Hispanic women, who are the people who qualify for the program, to overcome the structural barriers that they face so that they can access cervical cancer screening services. And we also wanted to examine the impacts of different barriers, different structures like urban versus rural residency, and how that impacted their access. And the COVID-19 pandemic. So with this in mind, we applied for some funding. PHCR believed in us, although sometimes it felt kind of difficult to ask for funding from a disparities program when we're saying, oh, can you give us funding to study something that is working? But they believed in us, and that was, we're entirely thankful for that. So in terms of methods, we had 5 virtual focus groups between March and June of 2021. And 2021, maybe the years, yes. 11 participants from Greater Minnesota, 12 participants from the metro area. We conducted all these focus groups through Zoom and recorded them. We also had 7 key informant interviews with SAGE and clinic staff with the idea that we were to see all the things that the clients and the participants did not actually see in their use of the program. We used conventional content analysis with 3 research members to identify themes and resolve discrepancies. So our participants, we had 23 focus group participants, all identified as Hispanic Latina women. The average age was 50 years old. 82% were born in Mexico. Some other countries were Ecuador, El Salvador, and Honduras. 90% had been in the US for 10 years or longer. All were up to date with their cervical cancer screening guidelines. We also interviewed 7 key informants. All were women of diverse ethnicities. So here are our main results. Participants identified facilitators at each level of the social ecological model. And I'm presenting the whole model right here to see how it works together, but I'm gonna unpack each of the levels slowly. So first, at the individual levels, we found more information about cancer in Minnesota compared to the places of origin. So for example, participants said, where I am from my town will know. There was no information about this, about cancer. Then I came here, when I got here, and we give you more or less information about this cancer disease, suggesting that generally information was available here, not education, information was more available here, and was very well distributed. At the individual level, we also found that self-care was a motivator for screening. This was contrary to our expectations. We were expecting that familism or motherhood to be a motivator, but that was not what came across with participants. Participants said that their love as women, as individuals, and as humans was what motivated them. So they often talked as having a rule of getting their Pap smear every year, so much that it angered them that the guidelines had changed now to only be every 3 to 5 years. It was very upsetting to them that they couldn't get their Pap every year because it was the rule for them to get that exam that is to no one with a cervix comfortable. And yet it was important to them because it was their health. It was their self-care. I'll let you read the quotes because it was kind of clunky when I read it. At the interpersonal level, we found that word of mouth was the main source of information, how information spread throughout all networks, so neighborhood, workplace, churches. And need to spread fast and efficiently. So for example, when people arrived to neighborhoods, to new places, they were lost. And then as soon as they arrived, the information was spread quickly about different resources, different ways they could get things, including the SAGE program. So there were fairs in which they found about the SAGE program, and they quickly transmitted information to their neighbors, their friends, their sisters. And the participants told us about when they found out about the program, and they also told us stories about when they told other people about the program. We found that positive past experiences with clinics and providers were a key interpersonal facilitators. So having that relationship, that trusting relationship with a provider, that good experience was wildfire. It was so important to get information moving. So when they were able to recommend the clinic or the provider, that's what got that information moving. So they found La Clínica del Migrante up in greater Minnesota, and La Clínica del Migrante quickly became the thing that they recommended to their neighbor, to their colleague, to their friend. And so that's what people would tell. At the organizational level, and this was one of the key and most important findings from our project, was the role that community clinics played in providing safe services cannot be highlighted enough. Community clinics were the center point because they can provide key and basic testing services. So they can do a PAP test, and they can also do HPV tests on their own without much more resources. And they have the infrastructure to diminish the additional barriers that exist for Hispanic women. So they have bilingual staff, they have bilingual providers, they have interpreters, and they importantly have usually a case manager that is entirely devoted to filling out and understanding what the SAGE paperwork is about. For larger institutions, this is not often the case. For larger institutions, they often manage this as a secondary insurance, or simply this is not their priority. So when women were referred to for additional appointments to bigger institutions that were not community clinics, that's when the problems started to arise, when billing and covered services and referrals, that's when the SAGE services started to get complicated. But community clinics handled it super well. They were at the center of the SAGE work and the SAGE program working well with this population. Again, thank God I found La Clínica, and that's when I also found SAGE program and I liked it. And linked with this, having bilingual providers, staff, and availability of interpreters. So even in places where they didn't have bilingual staff serving there all the time, having interpreters available was important for services to be used and uptaken by people. Finally, at the organizational level, having reminders from SAGE were reported from participants to be very important. They love that about SAGE, that they got an annual reminder or a whatever routine reminder about getting their mammogram. I do have to say that during our conversations, screening for breast or cervical cancer both topics came together. So sometimes they told us stories about one or the other without necessarily a differentiation, and we didn't care. We were still asking the same questions, right? So getting reminders from SAGE was very important, and they get postcards. They really like paper reminders, not email reminders. So paper reminders on the mail or calls was so important for them to keep going to their appointments. And like I said, everybody was up to date in their screening. At the community level, the presence of tight networks, church, employer, neighbors, they were very tight, even though they didn't need to be super good friends in order to be tight networks that just run together and supported each other. So this person, one of the participants talked about a woman at the church who, when she was just receive all the immigrants, all the new immigrants, and just help them navigate the system, how to pay the electric bill, how to where to go for the appointments, where to go for healthcare, where to go for this and where to go for that. And then now she's doing that for the next wave of immigrants, because it's just her responsibility as in this situation in this world. So suddenly it's like just tight networks just from existing, just from being part of this community. And this was really moving. We found really high levels of solidarity within the community. And the story that really moved us was one of the participants mentioned a story in which she was at work, and she overheard one of her colleagues talking to somebody else about her lump in her breast. And she said, I felt I didn't know what to do because it was a sensitive topic, but I had to intervene. So I intervened and I said, look, you got to check that out. And when her friend, or her colleague, it wasn't a friend, when the work colleague said, well, listed all the barriers and all the limitations and all the reasons why not to get to a medical appointment. I can't afford it. I don't know what to do. I don't speak English. I don't have insurance. I don't have documentation. She said, no. SAGE is there for you. You must go. This is a great program. It covers, it doesn't ask questions. It's free. You qualify. And then when the colleague insisted on all the barriers, she said, let me make the appointment for you. So she helped her colleague make the appointment, call the center, and help the appointment. And then, like she said, the participant said, but my friend was still very tímida, very shy. So I went with her to the appointment. So she went with her colleague to get a mammography scan, which is entirely an intimate exam. But it felt that it was her responsibility to go with her colleague to get this exam that was a life-saving exam. And it was just part of what they do for each other, what we do for each other. So this was the community level on the solidarity was it's a hard thing to replicate, but it's very important to highlight. And at the policy level, it's I alluded that a little bit. So there were low information requirements within SAGE and the partner clinics. And we talked about, so participants said, no, they don't ask for anything. They just ask you for your name, your address. They don't ask you for your papers. They just ask you for your name, your address, your age, and they already refer you to an appointment. Importantly, none of the participants mentioned this undocumented status or any legal immigration status. Key informants did talk about it, but in the focus groups, although we pointed in that direction several times, they kind of bypassed the topic of legal immigration in several occasions. Key informants were very, were more open about it, about saying that they serve people without legal documentation status, and that SAGE is a life-saving program because it is able to provide services that other programs do not, because they require more information. So low information requirements from SAGE and the partner clinics was very important for Hispanic women to keep using this program. And attached to this, a high confidence that their information was going to remain confidential within SAGE, that nobody was going to touch their information. So they would say, when I said, would you recommend the program to somebody else, and what would you tell them? They said the information, which is very confidential. We're trusting those people who say nothing, and let's not be afraid. So for them, they just gave their information. They just trusted the information was saved with SAGE, and they continue to use the program with that certainty. So yeah, I've covered all the facilitators at the policy barrier, at the socio-ecological model. I do have some additional findings that are worth noting. I'm gonna be a little quicker with those. So we did find lack of clarity of covered services within SAGE. And so receiving bills was a common topic throughout our conversations, and it caused a lot of anxiety and stress within the participants. Some of them came from a misunderstanding of what is covered. So for example, they went in an appointment and then it got confused. A participant didn't understand that the pharmacy bill for her diabetes appointment that was kind of scheduled simultaneously wasn't covered. So that bill was not covered by SAGE because SAGE doesn't cover diabetes medication. So that was a misunderstanding between in the communication between the staff, the provider, and the patient. So we do think it's important to improve provider and patient communication for that. And to that, during our key informant conversations, we did have different perceptions of what that appointment with women covered with SAGE should be about. So we had some of our key informants who argued that it was very important to use that appointment exclusively for cervical cancer screening and to talk about nothing else but about cervical cancer screening with the women, because they had the right to have an appointment exclusively about that and have an appointment about something else in a different moment. And another one of our key informants argued that in that moment, in those 20 minutes as a physician, you're suddenly in a world of insurance. And in that world of insurance, as a physician, you got to use the time to talk about all the needs of that patient in a one-stop shop, to talk about all the things that that patient is needing. You're not able to obviously provide the medication, provide the things that that patient might need besides the cervical cancer. But in those arguments, regardless of what should be done or not, I'm not a physician and I do not get to make the choice. But in those arguments, I think the patient may be lost in what is covered in SAGE and what bills she is going to get at the end of the appointment. And some were institutional mistakes. And most of these mistakes, if not all, came from larger institutions, not from community clinics, from just putting the wrong billing code. They did not they did not bill SAGE directly. They billed the patient because they didn't have insurance. And most of those things were resolved by calling SAGE or the clinic, but they did take multiple phone calls waiting for the Spanish line in SAGE that is handled by 2 people. So it puts a lot of the onus on the patient. And we had one of the patients who was very knowledgeable about this and told us about one instance in which she's called the administrative assistant in a clinic and say, I'm your patient, I'm not your billing person. You're supposed to know who to bill, not me. And to which I agree to. We also found, in general, participants from Greater Minnesota and from the Twin Cities, we found that they had similar positive experiences with community clinics and with SAGE. But we did find more barriers with participants of Greater Minnesota, some that you would expect, difficulty with transportation, availability of interpreters, but unfortunately also more experiences of racial discrimination. So a couple of participants talked about how when they approached the receptionist and said, can I get the SAGE paperwork? They're like, we don't have those pages. We don't have those documents, and kind of just dismissed them. And when the interpreter on the phone said, no, you do have them. You go look for them. She was like, and like was very dismissive and treated them with a lot of disrespect. And we have plenty of those experiences, mostly in Greater Minnesota, unfortunately. And the COVID-19 pandemic had some impact, but it wasn't a big barrier by any means. Some participants talked about cancellations of screening appointments, some from the provider side, some from their side because they didn't feel safe. But most had been rescheduled within the year. So it didn't feel like a large barrier when we talked about it. It felt like the conversation ended up fairly quickly about COVID-19. So just to conclude this, we want to highlight this community academic collaboration that identified facilitators at several levels. And we want to use these facilitators. We're hoping to learn from these facilitators for different programs. So like Rodolfo said, we think that we can learn from this to improve SAGE for this population, for this program, for this community, but also for other communities. There may be other communities that may have things in common with the Hispanic community that we might are just not reaching with the same way, that SAGE is not reaching the same way. And we're also thinking that we could use these values, these things that are very inherent to the Hispanic community, at least that we have seen in this about the Hispanic community in this project, and maybe hopefully talk about and see if other programs that are not reaching the Hispanic population the same way can tune into these values to reach. For example, Rodolfo mentioned Planned Parenthood has not been quite there yet, and other programs like that. And we do want to recommend for SAGE to include clarity of billing and covered services. And that includes at all areas, right? That from patient-provider communication, but also just working with clinic administrators to put the right billing code. And that community clinics work very hard, so much that they have to have a staff that it works exclusively or almost exclusively on filling out SAGE paperwork. That maybe it suggests that maybe the SAGE paperwork could be simpler, or that could be streamlined, so that the billing mistakes don't happen as often, or hopefully don't happen at all, because they do cause a lot of stress and anxiety on this population. And I'm gonna yes.
To the video, I want to say, I was literally going to turn on, or I can switch. Eventually, one of the concerns that we did have, it was kind of the willingness from participants to openly talk about this, and particularly because it's a very intimate issue, as Gabby was mentioning, but they were talking openly anywhere. And it didn't matter if it was a woman interacting with them, like in this particular situation, Gabby, or myself, they were openly talking about this. So they were confident talking about it. And it was, for me, a very big surprise. Another thing is that they were looking for advices. And so many times, Gabby, as PhD, she introduced herself as Dr. Bustamante. So she ended being asked about several issues, medical issues that she didn't have an answer for. But yeah, they were showing us that they need a lot of support. So that is also something I want to highlight in this interaction. And finally, I guess they are an open kind of need for them to being listened. They need to find different forums, different spaces for express themselves as what are the limitations they find in accessing the services, but also in understanding the follow-up process, because so many times they are just not really following up, and we see the incidence of cervical cancer is high because they don't know what to do afterwards. So we are very fortunate to register a very low death rate among patients, but still we need to see some improvement in there. So now Alex is going to introduce the video, but I wanted also to say and take the opportunity to thank Wilder Foundation for lending us this space. It's wonderful. I am aghast. You don't know, but we can switch cameras and we can zoom in and zoom out. So be careful when you are talking. And also that this event is being simultaneously transmitted via Facebook Live, where it's going to be recorded. So whenever you want to revisit and think about this, you can go back there. And some people are in Zoom. So those who are in online via Facebook or via Zoom, please just interact with us via chat. Let us know what you are thinking, if you have any questions that we are going to be entertaining at the end of the video. The video is spectacular, so please enjoy it. And Alex came on board kind of a little bit blind at the end of the project, but just in 2 days, she was an expert and she handled everything well. So that's why we invited her also to share her experience in being involved in this project as a very junior member of our team. So Alex.
Thank you, Rodolfo. Thank you, Gabby. Hi, everyone. I am Alex Jensen. I am a research associate at HACER, and kind of like what Rodolfo was saying, I think this was the second project I was put on once I joined HACER, and it was a whirlwind, but an amazing experience. And I think I'm so privileged to be a part of this project and get to learn these women and just get to learn all this information. And so today I was going to talk a little bit more about our experience with the video. I was able to first join this project when we got really into the data analysis. So that was getting into the focus groups, the key informant interviews. And so I kind of felt like I knew these women. I was there when the focus groups were happening, when the interviews were happening and all of this. And so when we were getting into setting up what are we going to do for this video that we're going to use to disseminate information on stage, we obviously thought who better to do this than the women who were in the focus groups themselves. I was able to work with Monica and Gabby, and we reached out to these women. And then in addition, it was Gabby and Monica that made this amazing script too that we had, and we chatted about the idea of we have someone kind of the similar situation of what Gabby explained, where there was a woman who just knew quite a bit about the SAGE services and what they provided, and then she was just telling a friend, a colleague or associate about what she knew about this program and what this program could do for her. And so we reached out to the participants, and funny enough, it was two women who were in Greater Minnesota, so even further away, that were very passionate and excited about being able to join this video and be a part of it. And you could actually see that too when we started recording the video as well. So the day of, we made plans on a Saturday, I think around noon, to have them come in. And that's when we were going to do the recording with Gustavo from Latino Media. And I usually get there a little early, just get ready for them because we had a back room space rented out. I got there probably 5-10 minutes early, and it was amazing to see the participants were already there. They had been there for probably 15-20 minutes, and they had printed off the scripts that we'd given them. They were already practicing. They had brought their families and their friends with too, from the drive from Greater Minnesota, because I think both participants, they had about a 2-hour, hour-and-a-half drive to get to the cities. And it was just amazing to see how passionate they were about, one, being in this video, and two, getting the information and sharing it and getting it out there. And like I said, too, they were just on their own, already practicing through the script. And to be honest, and I think Gabby shares this as well, the first time I saw this video, I'm not one to cry, but I think I got a little misty-eyed to kind of see like the full circle of everything. And so I know us all, Gabby, Rodolfo, myself, and Monica, Jessica, and Juan Pablo, if they were all here, they would be just as excited to show this video to you all today too. So thank you.
Hola Cristina, ¿cómo está? Buena, doña Marce, ¿cómo ha estado?
Ahí dándole, ¿y usted?
Un poquito preocupada, doña Marce, fíjese que no me ha bajado y tengo un dolorcito aquí abajo.
¿Qué será? ¿Cuándo fue la última vez que se checó?
Checarme ahí abajo. Desde que tuve mis hijos y ellos ya están grandes, no me he hecho un chequeo.
Uy, pero el Pedrito ya tiene 15 años, hace mucho tiempo. Tiene que checarse, hay que hacerse un chequeo regularmente.
No creo, Marce, a mí me da pena estar enseñando mis partes privadas. Allá en mi pueblo, mi mamá y mis tías nunca fueron al doctor y ellas están muy bien. No creo que haga falta ir.
Sí, es verdad, allá en mi tierra tampoco se hacían los chequeos regularmente y ni siquiera se hablaba del tema. Cuando a uno le venía su periodo y le tocaba comprar toallas sanitarias, lo teníamos que hacer a escondidas de los hombres por pura vergüenza. Cuando llegué acá a Minnesota es que me enteré que hay que hacerse un chequeo regularmente.
¿Regularmente?
Sí, antes era cada año que uno iba a hacerse el examen ginecológico y de las mamas, pero ahora es cada 3 años, dependiendo de lo que el médico te aconseje.
Cada 3 años. Uy, pero Marce, yo ni cuando estoy enferma voy al médico porque no tengo seguro y sale carísimo ir al doctor aquí. Seguramente usted tiene un seguro para ir al médico.
No, acá en la empresa de Manuel nos dicen que no tenemos derecho a nada, pero no es cierto. Hay muchas ayudas para nosotros los latinos y debemos reclamar nuestros derechos. Mire, acá cerquita hay una clínica que no te piden seguro y te cobran dependiendo de tus ingresos. Yo fui y me atendieron muy bien.
Pero Marce, usted habla inglés, por eso es que sí le entienden. Mejor solo aconséjeme un tecito, por favor.
No, Cristina, ahí hay muchas personas que hablan español, incluso hay doctores que hablan español, o si no, puedes pedir un intérprete.
Pero hoy estoy gastada, Marcela, tal vez el próximo mes, como sea, aunque me cobren poco, siempre es un gasto para mí.
Sí, Cristina, le entiendo, pero le cuento que aquí en Minnesota hay un programa especial que se llama SAGE y le cubre el examen ginecológico y es completamente gratis. Mire, le voy a dar los datos para que llame ahí. Ahí en SAGE hay también personas que hablan en español.
Uy, Marce, pero ¿usted sabe qué información me van a pedir? Me da nervios eso a mí.
No, no le piden nada, solo su nombre, edad, dirección y sus ingresos, pero no tiene que presentar papeles, solo es lo que usted reporta. Anímese, Cristina, porque ese examen puede prevenir el cáncer.
¿Prevenir el cáncer? No me diga, ¿cómo puedo hacer eso?
Sí, si se hace un examen regularmente de Papa Nicolau y le encuentran algo malo, pueden darle tratamiento antes de que se haga un cáncer. Verás, te explico, el cáncer de cuello uterino afecta al cervix, un órgano femenino que conecta el útero con la vagina. El 99% de los casos de cáncer de cuello uterino son causados por el virus del papiloma humano, o HPV por sus siglas en inglés, que es un virus de transmisión sexual. A nivel nacional, las mujeres hispanas tienen la mayor incidencia y mortalidad por esta enfermedad comparada con otros grupos raciales y étnicos.
Uy, Marce, eso seguro es por los genes que tenemos nosotros.
No, Cris, nada que ver. Esto es principalmente a barreras sistemáticas que afectan a nuestra comunidad, como falta de seguro de salud o información a nuestro idioma. Por eso es tan importante aprovechar que existe este programa de SAGE que disminuye estas barreras.
Ay, Marce, pero qué miedo de lo que puedan encontrar. Y si encuentran algo grave, seguro, ¿cómo voy a pagar ese bill? Me imagino que es un bill muy grande y no puedo pagarlo.
También hay ayudas para eso, Cristina, si llegara a pasar. Si le llegara algún bill, solo llame y ellos le van a ayudar. Con confianza, Cristina. Vaya, no lo deje pasar.
Tiene razón, Marce. Voy a llamar, lo voy a hacer.
Entonces recuerda, hacerse un examen ginecológico, el Papa Nicolau o una prueba de HPV regularmente puede prevenir el cáncer de cuello uterino al detectarlo tempranamente. El programa SAGE ofrece estos servicios gratuitos en todo el estado para personas que califiquen basados en ingresos, edad y seguro de salud. Gratis y en tu clínica más cercana. Muchas mujeres como Cristina han obtenido estos servicios que les pudieran salvar la vida. Es más, las latinas somos las mejores clientes de SAGE. A pesar de que representamos el 17% de quienes no tienen seguro, representamos el 60% de las clientes del programa. ¿Por qué? Porque somos fantásticas. Porque a pesar de las muchas barreras que enfrentamos como latinas inmigrantes, somos fuertes, resilientes, nos ayudamos entre nosotras y encontramos la manera de hacer las cosas que necesitamos. Hazlo por tu familia, hazlo por ti, tu salud importa. Llama ahora a Sage o pregunta sobre el programa en tu clínica más cercana. Si necesita ayuda, pídela. Acuérdate que todos tenemos derechos.
Thank you. And this video, as Alex mentioned, summarizes all our findings, and we are intending to bring it to the community for them to learn about it as well. So I am really proud of it, and it was a very wonderful work. The edition is just fantastic, I guess, and I am really excited. So I want to close right now just thanking my team, my staff who are here, and particularly Gutierrez, who's been handling all the media, and with all the fantastic equipment we do have, we didn't need the Zoom for the screen. We forgot it. But now it's time for questions and answers. So let's open the mic for you to even make comments or any suggestions that are going to be really welcomed. And we are going to try to answer from this side. But please feel free to raise your hand if you want to make any comment or any questions. Luis.
What's your dissemination plan for this information?
Yeah, well, initially is generating this kind of material that we do have the video, of course. We are posting the video in our website and in our social media. We want to bring it to other outlets such as Univision and M Latino Media that produced the video. And we want to publish some sort of one-pagers disseminating the information we do have. We used to have this kind of information published everywhere, and we are bringing our information, as you can see at the table. We are carrying information with us, and hopefully we are going to ask for help from the University of Minnesota also to disseminate the information. And we are going to connect with Sage for them to help us in going further. I don't know if you want to add something, Gabby?
Well, this meeting was certainly part of a dissemination plan. So the video is it was made by participants for participants, hence the Spanish. And it's meant to do a bunch of things, talk about the results of the project and give information about SAGE. We also wrote a long report that we are putting in on the website it should be available soon. But we also are planning to translate it and make one-pagers to disseminate to participants and other community members. The report is, we're planning to disseminate it to stakeholders, key stakeholders, so community partners, and including Sage, who I hope they're listening here. I think they're online. They've been incredibly supportive of the whole project. So that's, it's worth mentioning as well. Yeah. I think Rodolfo covered it.
Thank you. Thank you. Anybody else? I see Rosa and then, okay, Rosita.
Thank you. Thank you very much for sharing. And this is very valuable information. And but my question is, so from the very beginning, you were thinking in focusing on immigrant women. That's it. And then the data that reflects the high usage of SAGE, which is like 60%. Does that include also Hispanic Latina women born in the US? How did you decide what was going to be like the focus of your research yeah, the focus of your research? That's one question. And then the other question is more about what was shared during the focus groups. If any of the participants would mention the interaction with their providers or with their doctors, if they would prefer to be seen by a woman doctor or a man doctor, because sometimes in countries in Latin America, you used to see like gynecologists who are men, whereas here, I think that women prefer to see gynecologists who are women. So I don't know if there were any conversations around that and if that was an issue. Thank you.
Well, I'll start saying that we didn't have any specific target population, but it was the Latina users of Sage who were in this high rate of using. We didn't have kind of a previous separation between immigrants or not immigrants, but it happened that most of our participants were immigrants. And regarding the use, the preference of medical doctors, women or men, I don't remember anything, but I don't know if you have anything to say.
Yeah, no, we didn't ask about that. Or they didn't mention that. Yeah, and we definitely didn't make the distinction between their, we didn't talk at all about their immigration status. I am assuming from their other parts of their conversation and other things that they talked about, their work status and insurance status. Some of them may have had legal status at that moment of the conversation. Some of them may have not, but we did not talk about that. And all of them were immigrant women, but we did not distinguish between, it could have been first or second generation Latina women.
Right. And you saw in the video that there is this, in the conversation, one of the women says, you speak English, that's why it's easier for you. That means one of them is not necessarily undocumented, the other one perhaps is immigrant, or perhaps both are immigrants. We don't really know, but there is kind of this mix between users of the service. So
I just want to start out by saying thank you for doing this research. I have a bit of experience working with Sage from the provider standpoint, and I think it's a really fantastic program. I was just curious, speaking as a provider, if when you were engaging some of the stakeholders, if the financial incentive ever came up from the point of view of care providers, in the sense of, by definition, folks who are eligible for Sage are do not qualify for insurance, and so this is a way that providers would be able to receive compensation for providing these services to individuals. That was something that came up a lot when I would see patients who qualify for Sage. That was something that really kind of hammered home. So I was curious if you had any, if you encountered any information about that.
I hope I can answer the question if I understood it correctly. Sage, people can access Sage. Let me just start by saying that you can be eligible for Sage if your insurance requires copays for these services. But we did, and among the key informants, we only talked to one physician, and that one physician did not directly provide Sage services. That was one of the limitations of our project. We were not able to get a hold of a physician that provided Sage services to this population, or any population, so to speak, actually. So I don't know how that works, how the back part of the incentives, the financial incentives, but it's probably a barrier or a facilitator within the back, the infrastructure, the organizational policy level that needs to be addressed in a future consideration. Thank you.
yeah, thank you. And I must add that the most important incentive came out from the friends of the friends of the friends who were talking about the need of this. I remember one of the women saying, in my country, this would never happen. So I better take advantage of that, because where I coming from, that could never happen. So it was really, the incentive came out from this idea of those who were passing the voice, who were telling the people, this is important, so you better do it. And the people took it that way. So yeah, just to add to what Gabi said. So, right.
Hi, I'm Vanessa. I actually used to work at a community health center, actually right next door. From what I understand, there is some compensation for the background stuff, but it doesn't cover everything. So one of the difficulties is, as you mentioned, is that there is an onerous amount of paperwork. And so if you want to do a lot of SAGE participants, that can also almost be a full-time job, the amount of paperwork in the back. And if there was some reduction in that, perhaps there could be more, we could see more patients actually, because there's so many background pieces to that. I can see why larger health systems, if they don't constantly see SAGE participants, that they wouldn't know what to do, because it's like having to relearn it every time. But I don't know if the compensation currently makes it worthwhile for larger systems to want to participate, I can imagine. So I'm not sure as far as like provider coverage, what amount that actually is, but certainly for the care coordinators, I think it's more focused on the income for that to support all the care coordination basically.
Yeah. So yes, so we did talk to administrators of many community healthcare centers, and all of them had somebody who was almost exclusively dedicated to SAGE paperwork, which is a lot. It felt like a lot. So I learned a lot about SAGE administration during the process, although that was not necessarily the goal of but it did seem like it was a big deal, which bigger institutions didn't. It was just not part of what they needed to do. You had a second point. What was your second point? No. Okay.
Well, thank you. And this was really nice work and informative. I have two comments. The high incidence and low death means that there's more screening, because you only know that there is disease if you screen. So that is like, it's not to worry that there is more incidence, because they're getting screened at an early stage. So that is good. Well, there's another one. Larger systems, they don't accept people without insurance. So it's very hard for people to get there. So then to get SAGE, why would they do SAGE if they don't have any, they can't serve people without insurance. So that's a barrier in the general population, which makes it a big target to the community clinics, which works with very little money, a lot of disease, and a very difficult population. So that's another thing. And and my last question, you said that most of your all your participants were on target and they were working with SAGE. Did you try to reach participants? I know that participants who like programs like to participate. That's always a selection bias in any studies, but did you reach any that did not?
No, and that was so because of the structure of the study and the aims of the study, we did not try to representation was not our goal. We just wanted to see how in the qualitative aspect is this program may be working. So we didn't reach women who did not follow through. Although they may, of course, have a different perspective, because if they're not following through the program, they may have different opinions about. Obviously, these women were following through the program, so not only were they up to date with guidelines, they also liked the program enough to be part of the program. And 3, they loved the program. Like they couldn't, they started the conversation by thanking me for the SAGE program. And I'm like, I'm not part of SAGE. I had to say several times, I like SAGE. My colleagues in SAGE are great and the program is great, but I am not part of SAGE. Like, I'm like, they may be things that are not working well within SAGE. Can you tell them? They're like, no, we love SAGE. SAGE is wonderful. So I agree that there may be other viewpoints for sure. And the idea is not to extrapolate or at all from
But yet,
this.
that question brings us to the next Grand proposal for PhDR.
I'd like to make a comment and tell you a story. And great job. I'm so enlightened. I'm glad I came. I was invited and I work for HACER. And the story is that I am ancient. So to begin with that, I started my career at La Clínica. And when the first time Sage came to La Clínica, one of my jobs was to really disseminate this program among the Latino community, the Latino women. We didn't know, I didn't know about Sage. No one knew anything about Sage. The doctor didn't know anything about Sage. So we have to learn all together and disseminate this program. So one of our patients came and I told her about this great program and what she needed to do, pap smear and so forth and so forth. So she said, yeah, let's do it. And she must have been about 50 years old. And she had a stage 4 cancer. And then I have to interpret for the doctor when she told her that, I mean, this was not good news. And then what do we do about this? A recent immigrant with no insurance, with no money, with hardly any programs available to her. What do we do now? So I called the cancer center at the University of Minnesota, and I didn't let go until I talked to the physician, cancer physician, and I told him the story. And he says, we're not gonna charge her anything, bring her. So because they didn't have it at that time, I'm telling you, I'm ancient. They know no interpreters, nothing. So I went with her. And so they didn't charge her anything. She was admitted to the hospital later. They did all kinds of treatments and you know, all the things that need to be done. So in the end, she died. And that's stuck in my head. One of the things that has stuck in my head for the patients that I have interacted with. So this Sage is lifesaver.
Thank you, Angelicia. I am certain about that, and that's why our target population was Sage users, because really it's working. So it has to be working better in other spaces. Lily?
Can I just say something to that?
No, you can. Yes, of course.
Angela, I mean, that speaks to the solidarity that we see in this community, what you did and what people keep doing. And like so I spoke about the solidarity between two clients, but there was so much solidarity within the staff of the community clinics. They would work like 18 hours a day to get the paperwork to go for like salaries that did not match their time. Go with patients and like catch up and do things that were definitely not part of their roles because of the solidarity within the community. So like it was because people of and deeds like what you have done that the Sage program works and with this community. And I want to make sure to highlight all these things. So thank you. And you and people like you did a fantastic job of disseminating this program. That's why it's so good. 60% of clients.
I just, yeah. You know, Gabi, you briefly mentioned like what happens after the patient is diagnosed with something and then it has to enter into the system. And you kind of let us know that there are more complications and more barriers. I am curious if that is going to be your next step for the two of you, your next research step to know what are those things? Because yeah, once you have a diagnosis, what is next? What happens after that? I'm very curious to know more about that.
Yeah, that is a difficult question, Lily. So we had talked about a next step, and actually before the diagnosis, with the diagnosis is very difficult because actually Sage stops right there. The coverage of the National Breast Cervical Cancer Early Detection Program stops exactly the moment that you have a diagnosis, which is absolutely breaking. There are some options, very limited, of emergency medical access, but they're very, very limited. so that is a couple of steps beyond, but even within SAGE, there is a gap where we feel like some patients are falling, and some is part of what we heard from patients is this follow-up, right? So the community clinics are great at providing those HPV, those pap tests, but once patients need a colposcopy, which needs a specialized team, specialized equipment, then that is when it gets complicated and they need a referral to this additional other system. So they need mobilization, they need transportation, they need a referral, they need the right code so they don't get a bill. And in that process, we feel there's a lot of loss to follow up. Sorry, I need to turn that off. There's a lot of loss to follow up in the process. So we did had an idea. I actually wrote a little grant of this project, but I also took a job in Ecuador. So I'm going to be working there. And my colleague here has that project too. Hopefully put it through NIH or something. So yeah, maybe.
Yeah, we want to apply for a larger grant to bring her back to Minnesota.
Yes, yes. Gracias.
A question? Okay.
Just adding on to the questions about diagnosis, I was curious about like at what point is it considered a diagnosis? Did you guys look at false positives as part of the stories of people who are going through SAGE? Is that something that is being considered, or is it just as soon as they receive a positive? Or if that's something that you haven't looked at, that's fine. But I am curious about the elements of false positives and false negatives, and if that has been something that has been touched during the research process.
You have any answer for that, Alex?
I would say when it comes to the false positives or the false negatives, there weren't anything prevalent in any of the focus groups or any of the key informant interviews that touched on that. I think, mind you, I know quite a few people in here, pretty much everybody is more of an expert than I am, but I think false positives are extremely rare. And so that was one of the things that never really came up, but it was restated and reaffirmed with quite a few different key informant interviews that it was very confusing for the participants that once they got that diagnosis on what's next. And so that was one of the huge things that we, again, kind of that was mentioned in previous answers, was a huge thing that we wanted to kind of find out more about.
Yeah. You know, in fact, yeah, we didn't have that evidence of false positives and otherwise. Yep. Coming to you.
First of all, thank you for this presentation. It was really excellent just to hear all this information. You talked a lot about the strengths of the community, and it sounds like SAGE has really good follow-up. They have bilingual and bicultural staff, which have really contributed to their success. But did anything else come up about what SAGE is doing to really build trust with the community and just have this strong presence versus the community being the one to like make this program successful? Because a lot of times, you know, I work at HACER, we contract with a lot of people that are like, how do we reach the community? How do we reach this community? So at least in my opinion, it should be on the organizations trying to reach us to do that work. Certainly we can support, but it shouldn't be that people are working 18-hour days, et cetera, to help each other out. Like, that's great, but the responsibility shouldn't be on us. It should be on those organizations. So I'm just wondering if that topic came up at all, and if there's anything that other organizations can learn from SAGE to better reach the community.
Yeah, I'm going to start saying that, yeah, the staffing they are going through, they have magnificent, excellent staff persons. Socorro is marvelous. She has a very open and a clear connection with the community members. And I guess that is a key factor that it's been helping SAGE to be more or less more successful in that area than anything else. And she also has a lot of people who help her and she has the right connections. But also, what else?
I love your question. It's making me think. I would say it was an early investment from Sage at some point. And they do have 2 Spanish speakers from the staff, and no other language are spoken within Sage. So they have invested in Spanish speakers. As far as I know, last time I was there, so they may have changed that, but so they have invested in doing that and reaching the Hispanic community. And I think they have done that a couple some years ago. But my sense from the focus group participants and from the key informant interviews was that at this point, the community is driving this information. The Sage does show up in community in fairs, in health fairs, and like they have the mammograms that go in the mobile mammograms that go to different places. But it generally moves through the community, the information and the recommendation. That is what is so rare, I feel, about how this program is so successful in this community. I don't know, Alex, did you get a different sense? Because we hadn't thought about this question, so thank you.
Cancer survivor. I was going to say there was it Julissa? Yeah, she was part of a cancer survivor group. And again, that's not something that Sage was doing to kind of help those who work with it. But there were other ways that they were reaching the community to kind of come off of, I'm trying to think. But that was the one that stuck in my head that you were talking about, was that Julissa was in cancer survivor groups and they would share all this information. But yeah, but she was, but that was the key difference is Julissa is part of a community clinic and she wasn't specifically a Sage, worked for Sage. But I think a lot of those who worked with community clinics kind of are the secret advocates of Sage. And so I'll say that.
Comments?
I hope the paperwork has better, because that was one of our big complaints about the paperwork that we needed to do. I hope that they have improved it now.
It didn't seem like it, but I hope so. I hope that that's something that they can streamline.
So in the grants, were you associated yourself with Sage as part of the grant, or it was just the organization that you discovered in your path to looking for recruits, if you will?
No, I had conversations with Sage before I even talked with Rodolfo. And instead I was learning about cervical cancer in general. So Sage, I was working with Sage in other projects, collaborating with them. And they were open and supportive, very much. So much that all the recruitment happened through Socorro's help. Poor Socorro had to call and call and call many women, but it was thanks to her that we got a lot of participants, because people trusted her voice. And like some women were like, yeah, what are we here? We're like, yeah, for participation, the University of Minnesota. And I said, yeah, whatever's with Sage, we love Sage. And, so some women didn't even remember what they were saying yes, because as long as Socorro and Sage was involved, they trusted Sage. And
so
yeah.
just sort of the clarification in terms, we use the word incentives earlier. So typically we think about incentives as being something you give a gift card, but that wasn't the case in this study. So you didn't mention how those incentives work.
We did give them at the end of the participation, we gave them a $20 gift card. Yeah, we sent them to their home address.
Is that how you were using the word incentive earlier, or was it the access to the
in this last words that I said, I don't remember saying incentive. No, the incentive was just, but they didn't know. We did disclose to them about the incentive. Some had even forgotten about the financial incentive, but for them, they wanted to participate because they wanted to give back to SAGE a little bit.
Yeah,
that was my sense.
Some of our participants said that they were going to be participating even though they didn't have any money. So yeah, they wanted just to participate in the study, in this process.
So this is just kind of touching on some of the themes that were raised earlier, but have you talked to SAGE about the results from that perspective of what is really working in this community? And do they have thoughts about how they might take this to other communities like you were hoping they might do? Any kind of preliminary ideas or conversations you've had about that?
No, we were hoping that they were going to come here.
Yeah.
So no, not yet. We had been working very hard on getting the report ready. And we're going to make sure to share it with them. I've shared a little summary with the leader of SAGE. So yeah, I've shared some information, but not had a full conversation, but I'm looking forward to that for sure. And they've been very open to the whole project and the conversation. So
if something happened is at the Masonic Cancer Center conference, I had the opportunity to talk to someone from SAGE, and I mentioned this study, and they said that they were going to be in touch with us, but hasn't happened yet. But yeah, it's as far as we've been going till today. But yeah, we're going to keep on knocking their doors because I guess it's good to recognize their work, the work they are doing. Thank you, Michelle. Well, anybody else? Well, I want to insist this is a wonderful story. I am really thankful with Gabriela because she really helps us in building a beautiful project. And all the members of my team came on board, and it's really great. They found a very great collaboration here and a very good reason to participate. As I said, the transformation I've seen, like in Alex, as a researcher, is just fantastic through this project because it was very well structured. And I want to thank to PHDR, University of Minnesota, for the support, because with this, Si Se Puede, we can really learn more and move forward and establish better goals for the future of our communities in healthcare access. And this is very important for me. And before closing, actually, I want to thank you all for coming, and thank you for following us. And please follow us. And where is it? And Facebook. Thanks.
Thank you, Rodolfo.